The most dangerous blood pressure reading as you get older isn't always a high one. Sometimes it's a normal one because the target most doctors are still using, 120 over 80, was built around a 40-year-old body, not a 65 or 75-year-old one. For some of you watching this, chasing that number could be doing the opposite of what you think it's doing. I'm Dr. Claire Brooks, and I want to spend the next 20 minutes walking you through this properly, not a soundbite, not a headline, the actual mechanics of what happens in your body as you age, why the standard target stops making sense for a lot of people past 60, and exactly how to figure out where your own number should sit. By the end, I'll give you a simple test you can do at home this week and something every adult on blood pressure medication in this age group genuinely needs to hear. Let's start at the beginning. Most people think blood pressure is simple. High is bad, low is good, that's the whole story. And when you're younger, that's often true enough. Somewhere in your 60s, 70s, and 80s, it stops being that simple, and almost nobody explains why. Here's why. Your blood vessels change structurally as you age. The walls of your arteries, which were once flexible and elastic in your 30s and 40s, gradually stiffen. Collagen builds up in the vessel walls. Elastin, the protein that lets vessels stretch and recoil with each heartbeat, breaks down and isn't replaced the way it once was. The result is a blood vessel that behaves less like a flexible hose and more like a rigid pipe. That stiffening does two things, and only one of them gets talked about. The first thing, the one you've heard about, is that stiff vessels push your baseline blood pressure higher over time. That's a big part of why blood pressure tends to climb with age in the first place, even in people who've never had a weight problem, never smoked, and eat reasonably well. It's not always lifestyle. Sometimes it's simply the mechanics of an aging vessel. The second thing is the one almost nobody explains, and it's the one this whole video is really about. That same stiffness makes your body significantly worse at adjusting blood pressure moment to moment. When you stand up, when you're dehydrated, when you're in a hot shower or a hot room, when you haven't eaten enough that day. A younger, more elastic vascular system can compensate for all of that almost instantly without you noticing a thing. An older, stiffer one lags behind. This lag has a name: orthostatic hypotension. And most of you watching have already experienced a mild version of it without knowing what to call it. You stand up too quickly, and the room goes hazy for a second. You step out of a hot shower and suddenly feel lightheaded and have to grab the counter. That's not just getting older in some vague sense. That is your blood pressure regulation system failing to keep pace with a sudden demand from your body. In a 40-year-old, that lag usually means 1 or 2 seconds of mild dizziness, and then it's over. In a 75-year-old, that same lag can mean a fall. A fall can mean a hip fracture. A hip fracture, particularly after 75, can be the beginning of a cascade: a hospital stay, a loss of mobility, sometimes a permanent loss of independence. This is not a dramatic exaggeration. It's one of the most common ways I've seen an otherwise healthy older adult's life change overnight. And here's what concerns me most about how this conversation usually goes in a standard appointment. We've spent years correctly warning people about the dangers of high blood pressure, the strokes, the heart attacks, the kidney disease. All of that is true, and none of it should be dismissed. But what gets left out, especially for people past 60, is that overtreating blood pressure can, in specific circumstances, be more dangerous than the blood pressure itself. That sentence alone is the reason I wanted to make this video. Let me make this concrete, because numbers on a page don't mean much until you see how differently they play out in two real people. I think about two patients often, both around 75 years old. Both walked into clinic with the exact same reading: 142 over 92. Patient A is active. She walks most mornings, gardens most afternoons, mentally sharp as ever, and tolerates her medication without a single side effect. No dizziness, no falls, no balance concerns of any kind. For a patient like this, treating that 142 and bringing it down meaningfully reduces her stroke risk over the next decade. Her vessels, in her brain, her kidneys, her heart, genuinely benefit from a lower number, and her body has the resilience and the regulation capacity to tolerate the medication without struggling to keep up. Patient B is a different picture entirely: more frail, managing several chronic conditions at once, balance already shaky on a good day, gets visibly dizzy just standing up from a kitchen chair. For a patient like this, aggressively pushing that same 142 down toward the textbook 120 over 80 could do far more harm than good. Every additional point shaved off that number raises the odds that his already struggling regulation system can't get blood to his brain fast enough the next time he stands up. The exact medication dose that helps patient A live longer and healthier is the same dose that could put patient B on the floor, in the emergency room, or worse. Same cuff, same number, two completely different risk profiles. This is honestly the part that concerns me most about how blood pressure guidelines get applied in everyday practice. In many of the studies that produce the guidelines your doctor is working from, patients like patient B, frail, multiple conditions, prone to dizziness, are routinely excluded from the research in the first place. The guideline gets built on people who look like patient A and then gets applied to everyone, including people who look like patient B. That mismatch is the single biggest reason a one-size-fits-all target for everyone over 60 simply doesn't hold up in the real world. Before we get to your actual target, I want to add one more layer because it changes how you should even interpret the number you're handed at the doctor's office. Some people have what's called white coat hypertension. Their blood pressure reads higher in a clinical setting purely from the stress of being there and is meaningfully lower the rest of the day at home. Treating someone based purely on that office number can mean over-medicating a person whose real day-to-day pressure was never actually a problem. The reverse also happens, and it's arguably more dangerous because it's more often missed. It's called masked hypertension, a normal reading in the office, but elevated pressure the rest of the time at home, especially early morning. Someone with masked hypertension can walk out of an appointment reassured your numbers look fine while their vessels are quietly under sustained pressure the rest of the day. The only way to know which category you actually fall into is home monitoring. Multiple readings at different times of day over at least several days, not a single number taken once in an office. If you've never done this, it is one of the single most useful things you can bring to your next appointment. I want to spend a few minutes on the things that genuinely support healthier blood pressure regulation at this stage of life, because this isn't only about medication dosing. Hydration matters more than people over 60 tend to think. Mild dehydration is one of the most common, most fixable contributors to orthostatic symptoms, and it's often overlooked because thirst signals themselves become less reliable with age. You can be meaningfully dehydrated before you ever feel thirsty. Sodium and potassium both matter, and it's the balance between them, not sodium alone, that tends to get overlooked. Diets rich in potassium, vegetables, legumes, fruit, support healthier blood pressure regulation alongside sensible sodium intake, not instead of medical treatment. Movement matters, and not in a dramatic way. Regular, moderate activity, walking in particular, supports vascular flexibility over time and helps your regulation system respond better to position changes, which directly reduces orthostatic symptoms. Standing up in stages helps immediately today, with zero cost. Instead of going straight from lying down to standing, sit on the edge of the bed for 30 seconds first, then stand slowly. That single habit prevents a meaningful share of the dizzy spells and falls I've seen tied to blood pressure medication in older patients. None of these replace medication when medication is genuinely needed. They work alongside it, and for some people, they meaningfully reduce how much medication is needed in the first place. But that determination has to be made with your own doctor, adjusting your actual prescription, not by quietly changing what you take on your own. I want to say this as plainly as I can because I don't want anyone walking away from this video with the wrong takeaway. High blood pressure absolutely still matters. Untreated hypertension silently damages blood vessels for years, often without a single symptom, and it genuinely raises your risk of stroke, heart attack, heart failure, and kidney disease. Nothing in this video is an argument against treating high blood pressure. The argument is narrower and more specific than that. After 60, treatment has to be weighed against your actual symptoms and your actual fall risk, not chased blindly toward a number that was designed with a 40-year-old body in mind. Good blood pressure management after 60 isn't about hitting the lowest possible number. It's about hitting the number that protects your vessels without putting you on the floor. If you're currently on blood pressure medication and something about how you feel day to day doesn't match what the chart says your target should be, that mismatch is worth a real conversation with your doctor, not silence, and absolutely not quietly adjusting or stopping anything on your own. Stopping a blood pressure medication abruptly without medical guidance can itself be dangerous, sometimes causing a rebound spike that's worse than the original problem. The right move is always the same: bring your symptoms, bring your home readings, and have the conversation. I want to be direct with you. There is no single perfect number that applies to every person over 60. Anyone telling you otherwise is quoting a guideline, not giving you an answer tailored to your actual body. Here's the general shape of it. If you're over 60, generally active, and tolerating your medication well without symptoms, aiming for a systolic pressure below 140 is a reasonable goal. And for some people in that category, closer to 130 is a reasonable and well supported target. That's the group the standard guidelines were largely built for, and for them, the guidelines are genuinely useful. But if your current treatment is leaving you dizzy, weak, foggy, or unsteady, or if you've had any falls at all, or your blood pressure drops noticeably when you stand, that conversation changes completely. At that point, your symptoms are telling you something the cuff is not, and your symptoms should win that argument every single time. If that's you, your target may genuinely need to stay in the 140s rather than being pushed lower, specifically to avoid triggering orthostatic hypotension and the fall risk that comes with it. I want to be very clear about something. That is not a failure of treatment. That is not you doing it wrong. That is the correct individualized target for your specific body, and if your doctor hasn't discussed this distinction with you, it's a conversation worth starting yourself. Here's a simple, genuinely useful test for orthostatic hypotension that takes about 5 minutes and requires nothing but a home blood pressure cuff. Step 1. Sit down comfortably, feet flat on the floor, and take your blood pressure. Write the number down. Step 2. Wait 2 full minutes, staying seated and relaxed. Step 3. Stand up and take your blood pressure again within 1 minute of standing, ideally right around 60 seconds after you're on your feet. Now compare the two numbers. If your top number, the systolic, drops by more than 20 points when you stand, or your bottom number, the diastolic, drops by more than 10 points, and you notice any lightheadedness, unsteadiness, or that hazy feeling when you stand, that combination is orthostatic hypotension. Do this on 2 or 3 separate days, ideally at different times, since it can vary depending on hydration, time since your last meal, and even the time of day. Write each result down. Then bring that specific finding to your doctor by name, say the words orthostatic hypotension, and show them your numbers. That single piece of information can change your entire treatment plan, sometimes in one visit. If this changed the way you think about your own numbers, I'd genuinely like to know. Tell me in the comments what target your doctor currently has you working toward, and whether anyone has ever tested you for orthostatic hypotension before. I read every comment, and your answer might be exactly what someone else watching needs to hear before their own next appointment. If you found this useful, share it with someone in your life managing blood pressure after 60 aughts, a parent, a spouse, a friend who mentioned getting dizzy standing up and brushed it off as nothing. This is the kind of information that's genuinely under-discussed in a standard 15-minute appointment, and it deserves better than that. This video is for general educational purposes only and is not personal medical advice. Every patient's situation is unique. Talk to your own physician before making any changes to your blood pressure treatment, and never stop or adjust a prescribed medication without their guidance.